sleeping more or less than usual? What about these balance problems? I just got whacked in the head with all that. I have dizziness and balance problems. Yeah, my gait can be off a little bit. These are just some symptoms. Cognitive findings: being a little foggy, difficulty concentrating. When your head hurts, it's hard to concentrate. You know what I mean? You might have a little bit of amnesia around the events. You might not remember exactly what happened. Emotional. Where does that injury occur if you become more emotional?
The
Frontal lobe. Frontal lobe controls your emotions, your decision making, things like that. And somewhere in our lecture, we're going to have the picture of the brain with the different lobes and what happens if there's an injury there. Because you need to know that, because if my patient has a stroke in a particular area, I can predict that they're going to have these complications. So we'll see that somewhere in these 5 hours. This is just a picture with all the little things, you know, pictures, and they help you remember stuff. But we're going to talk about the bleeding, watery discharge from the nose and ears with one of these head injuries. And so you need to know about that. And that is this basilar skull fracture. And that's the fracture at the base of the skull. What is battle sign? What does that mean? It's what? Say it again. Yeah, it's this right here. They have the bruising behind their ear. That's called the battle sign. And then these are the raccoon eyes, where that particular fracture causes the patient to have 2 black eyes. What is rhinorrhea? Okay, the runny nose. And then otorrhea. What is otorrhea? The fluid from your ear. And then cranial nerve palsy. What does that mean? What's palsy mean? It's, yeah, there's some sort of paralyzation to the cranial nerve. So this can affect some of the cranial nerves. Cranial nerve 5 is which one? What does it affect? The muscles in your face. That's why people who have Bell's palsy have that, they can't control the muscles on that side of their face. So this right here is what I want you to get from this. If your patient has drainage from their nose or ears, if you collect it on a little 2x2 or a white Kleenex, you can tell if it's cerebral spinal fluid because it gets this little halo around it. So it'll separate the drop of blood, the cerebral spinal fluid, and it'll have the little halo. It's called a halo sign. So if my patient comes in, they have this skull fracture, and they have this drainage from their nose or their ears, what am I going to do about it? Ooh, lay them flat, sit them up. Ooh, that's a good one. What do you think I would do about it?
You set them up to decrease their...
So sitting them up about 30 to 45 degrees is going to decrease the pressure a little bit and maybe slow it down. Do I want to put cotton balls in their ear and try to stop it?
No.
No, I'm not going to try to stop it. Okay, well, let me ask you this. Do I want to stop it? Like if a patient comes in with a bloody nose, you know, they put those fancy tampons up their nose and try to stop the bleeding. Do I want to do this with cerebral spinal fluid?
No.
No, I'm just going to let it drain. What's my big complication? If cerebral spinal fluid is draining out of the ears and nose, what can my big complication be? Infection. Because if cerebral spinal fluid can get out, bacteria can get in. So my patient's at a higher risk to develop meningitis. Which, don't get lost on meningitis. It's on level 4 syllabus, okay? You just need to know that I'm protecting them from infection because that's what can happen. But we're going to talk how to take care of the patient with meningitis in level 4. So we're going to talk about brain tumors. Do brain tumors belong there? No. They're space-occupying lesions. They're taking up space where they don't belong. Can they cause problems just like a head injury?
Yes.
Can they cause problems just like your stroke patient?
Yes.
Yes, they can have the same kind of problems. It just depends on the location of the brain tumor, the size of the brain tumor, because if they're small and slow growing, who's in the door?
No, and it's the outside door, people going in and out of that.
Can y'all hear the toilets from upstairs flush too?
Yes.
I haven't taught in this room before, but in that room you can hear them all flush all day
Sounds
long.
like they throw tables and chairs
That's
and
what I
stuff, like
thought.
really
Wow.
loud, like sliding them across the floor.
Every day. Every single day.
So, anyway, let's talk about these brain tumors. It's very annoying. My desk is right by the toilet, that's why I asked. I get to hear it all day long. So, the brain tumor depends on the size, how severe my symptoms are going to be, and the location, exactly what symptoms I'm going to have. What do you remember about brain tumors from level 2? Are they hard to treat?
Yes.
Why are they hard to treat? Because why? Okay, if I do surgery, most brain tumors have those little fingery projections that are in the brain tissue. So whether my tumor is malignant or benign, and I'm trying to get it all out of there, I can disrupt healthy brain tissue in the process. So surgery is the treatment for it usually, but they can't always remove all of the brain tumor because of the way it digs into the brain tissue.
What is it? I heard something last year they talked about if you break it up and then it'll spread faster.
Yes, if the tumor is encapsulated, like all one piece, and has the capsule around it, and you start breaking it up in pieces, then little cells and parts can float around in the cerebral spinal fluid. So if they can take it out in one piece, is the best way to go, but with the little fingery projections. Benign tumors are cancerous or non-cancerous? Non-cancerous. Malignant tumors are cancerous. If they both grow with the little finger projections, does it really make a difference if it's benign or malignant? Am I going to have the same symptoms? The same treatment options with surgery anyway. The cancer can spread, the benign tumor's not going to, but they're both going to grow at whatever rate of speed they grow. So, in your book, there's a gazillion names and ways to classify these. So, the primary classification, is it benign, is it malignant, or is it metastatic? What does metastatic mean? It's spread. So I can have a tumor in my brain, but it could be lung cancer or colon cancer. I can have a tumor in my brain that came from the brain tissue itself. That would be a primary malignant tumor of the brain. Metastasized come from lung cancer, breast cancer, colon cancer, but they all cause the same problems. I do not want you to learn 500 names for brain tumors. That's just ridiculous, okay? Your second classification is where it happens in the brain. And then the third classification is the cellular origination. Anytime you have a patient, though, that has a tumor, a brain tumor that has a glioma, that is always a malignant tumor. That's how they classify the name, is a glioma. I don't want you to learn all these names. What I want you to understand is that if I have a tumor, regardless of which kind it is, where it's at, or whether it's cancerous or non-cancerous, the location and the size and the speed that it grows is what's causing my symptoms, okay? The care for that patient is always safety first. So we're gonna make sure our patient's safe. What did we talk about chemotherapy in brain tumors? Okay, if I give chemo through a port or a peripheral IV, it cannot cross the blood-brain barrier. So is it effective?
No.
Nah, not particularly. You can do it with an epidural shunt, where they put the chemotherapy directly into the client's epidural space in the cerebral spinal fluid. That's somewhat effective, but the primary treatments are radiation to shrink the tumor, and then surgery to remove what they can remove. Look at these signs and symptoms of your tumors. The vomiting, the mood swings, the headaches, the speech. Do those sound exactly like your head injury problems?
Yeah.
Where I got whacked in the head with something? So can you see how your symptoms are the same regardless of what your cause is going to be? Complications of the brain tumor. cerebral edema and inflammation. Because if I already have this tumor in there taking up space, and now it's pressing on the blood vessels, and I'm either not getting blood flow, or I have no cerebral spinal fluid, is that gonna be a problem? That's a problem. I have edema in the brain tissue, and now that's taking up more space, so I'm gonna have increased intracranial pressure. It's neurological deficits, depending on where it is. What if it's in my occipital lobe? What kind of clinical manifestations am I gonna see? Vision, changes in vision. What if it is in my temporal lobe? Okay, hearing, it can have something to do with my speech, and I can have wernicke's aphasia, depending on where it is. Does my temporal lobe have anything to do with balance?
Yes.
It can have something to do with balance. What about my parietal lobe? What does it do?
That's your arithmetic.
It's my arithmetic, my spelling. It's also the lobe of the brain that if I close my eyes and she puts this pen in my hand, I can say that's a pen, or that's a key to a house or something. That's my spatial activity that I can figure out what it is. What if it's in my cerebellum? Balance and gait. What is hydrocephalus?
Fluid on the brain.
Water in the brain, but what is it really? Too much what? Too much cerebral spinal fluid is what it really is. Now, when you have water on the brain and it's a baby, do they have the mechanism to adapt to that? Yes, because their skull's not fused yet, so as they have more fluid, their head can just stretch. But when your skull is fixed in a hard box, and now I have increased cerebral spinal fluid, there's nowhere for it to go. So it's going to increase my intracranial pressure. Then we're going to talk about these particular tumors of the pituitary gland. I know you just talked about the pituitary gland. This should all be old news. Diabetes insipidus and SIADH. Okay? If I have a tumor in my pituitary gland, which one of those is going to occur? Either one. It's just hit and miss. Either one. Depends on how it is. I think I have more about that later. We'll talk about that on the thing. Here's our treatments for brain tumors. Chemotherapy, very limited. Radiation therapy, and then they can do craniotomy and remove the tumor out of the brain. We're going to talk about the craniotomy and the care of that patient in level 4. Don't worry about that, okay? Just know that that is the treatment, the surgery to remove that tumor. As much tumor as they can remove.
They don't do the seeds?
They do the radiation seeds, yes. That's what this picture is right here, where they go in and they implant the radiation seeds. And then this one is the radio stem, where they radiate through. What kind of problems can your patient have if they get radiation? It kills everything around it. It's pretty precise. I mean, you're marked and it's pretty precise, but as it's going through your skin and your skull to get to the tumor, what's it doing to your skin? It's killing the skin cells, and you can actually go away with a burn from the radiation. When my son was little, he had radiation to his, he had it to his abdomen and to his entire spine, but his right abdomen, and he was just scarred and burnt the whole time it was going on. And now he's 31 years old, and now he had some problems when he was in college with his digestive tract, and he had a surgery, and the doctor said, I really hate to tell you this, but the side that was radiated is like a 65-year-old man's intestines, and the side that didn't have radiation is like a 21-year-old's intestines. So it has long-term effects on all the organs that are radiated.
Can it weaken the balance in the skull? Could it weaken the balance in the skull?
It could. It could.
So
Would
that
they
goes
like
through the
recommend a
skull?
helmet or not?
No, but with the craniotomy, they would have a helmet. If they leave the piece of the skull out, you're gonna have to wear the helmet to protect your brain until it's healed up. These are the special tumors we're going to talk about. Acoustic neuromas. You need to know about those. There's a little section in your book under brain tumors about acoustic neuromas. They grow right here around cranial nerve 8 in the labyrinth of your ear. So what kind of symptoms do you think this guy's going to have? Yes, he's gonna have the same symptoms of someone with Meniere's disease. He's gonna have hearing issues, he's gonna have balance issues, vertigo, things like that. This tumor is very hard to operate on because it grows all around the nerve right here, the facial nerve and the acoustic nerve, and it grows all around the labyrinth in the ear, and it's very, very difficult to remove. So that's one of the special tumors that you need to understand and know about what your symptoms, your patient's gonna have, and what you're gonna do about it. The cranial nerves, you need to know the cranial nerves, the ones I have marked, because this one right here has to do with your hearing, cranial nerve 8. And these other ones that I have marked, 9, 10, and 5, have to do with chewing and swallowing. And when we're talking about cognition problems, and we're talking about brain tumors, and any kind of thing that affects your chewing and swallowing, you need to know those. And we already talked about the eye ones, the ones you need to know for the eyes. I'm just going to tell you, I don't care about the one for your nose, cranial nerve 1, although Ms. Cooper says that I'm wrong, because if you can't smell peanut butter, you're going to get Alzheimer's disease. So she thinks that 1 should work all the time. So I don't know if that's true or not, but that's what she tells me. And Ms. Coleman smells peanut butter every day to make sure she can still smell it. It's the weirdest thing upstairs you've ever seen. But if you can't smell peanut butter, you're going to develop Alzheimer's. She probably did. They're obsessed with it up there. So, but you don't need to get lost in these cranial nerves, because who does cranial nerve assessments? A neurologist, a doctor can, a physician, nurse practitioners do. But you need to know which cranial nerves are which, because if you go in and check on your patient, you need to be at least able to recognize that there's some sort of a change or something's different, and notify the physician or healthcare provider that something's going on with your patient. And it would be nice if you at least knew, which ones you're looking for, what cranial nerves. You don't want to sound dumb when you call them. Well, I went in there this morning and he could swallow, but now he's having difficulty chewing or swallowing. You know what I'm saying? So it's just good to be on the lookout for those. You don't have to get lost in this slide though. I'm concerned about the ones that affect your vision. I'm concerned about the ones that affect your hearing. And I'm concerned about the ones that affect your swallowing. And we're going to a convention, and you know that lady's probably going to be there to do that same thing you've already heard 3 times. The one lady who does the cranial nerve stuff. Trust me, I've heard it at every convention we go to. Pituitary adenomas are your other special benign tumors. They're not cancerous, they're benign, but they cause problems because they're wrapped around your pituitary gland. Causes endocrine dysfunction and visual disturbances. So why, I don't have a picture of a brain right here, I don't think. Why would the pituitary tumor, right, the optic nerve runs right beside the pituitary gland. So if I have a tumor in my pituitary gland and it's pushing on the optic nerve, it's going to cause vision changes. And then it's going to cause hypo and hyperpituitary symptoms. And you just talked about those in level, or in metabolism, we're going to review them real quick. If my patient has hyper ADH, too much antidiuretic syndrome, okay, what do they look like? Fluid volume overload. They have too much fluid volume. What does their urine look like? Super concentrated, a small amount of urine. What is their mental status like? Okay, why are they disoriented? Sodium level is low because why? Diluted. They have too much vascular fluid, so their sodium level is low. So if I have SIADH, I have a patient who has jugular vein distension, a full bounding pulse. Do they have peripheral edema? No. It's a disorder of water. They don't have peripheral edema. It's all vascular edema. Low urine output, super concentrated, and a low sodium level. If my patient has diabetes insipidus, what do they look like? Okay, They're dehydrated, they have the sunken eyes, they just look sick. What do they need? Fluid, they need fluids. Who is it? You getting yelled at from someone else now? Did you need something, Laura? Okay. We have class, so I don't know. We have a meeting at 2:30 about these, where's your time clock?
Over the way over there on the other side.
After the time clocks, it don't work. They were supposed to start Wednesday. Do they work today?
Nope.
Okay. I don't know, they're giving us an in-service about me today.
No, Miss Husley tried mine the other day.
They haven't
Didn't
worked so
work.
far, so. But we use them because we have what? A QED. And we're worried about attendance and punctuality, right? Did anybody ask you on Monday? Or Tuesday when they're here in the building? Okay, diabetes insipidus. My patient's dry. They need fluid. What's their urine look like? Clear. Clear. How much? A lot. They're always up and down to the bathroom. So you need to know the difference between those two. If I have a pituitary tumor, I can have either one of those. It just depends. They can be caused by the tumor. It just depends on what your pituitary does, which one's going to be the problem. So I gave you a list right here of symptoms. I don't know where this slide came from, but that edema is wrong. That needs to be taken off there. I'll take it off the one I post for y'all. They do not actually have peripheral edema. Okay. They can have pulmonary edema, yes. They do not have peripheral edema. That's the only thing that's wrong out there. What does the word ataxia mean if you see it on a test? Yeah, discoordinated movement, difficulty moving, especially with ambulation. Let's see if there's anything else up there. You should know all those other words. I just want to make sure, because I'm just going to tell you, on one of my evaluations, it said Miss Geary uses big words that we don't understand.
What?
So level 2, we did lots of defining words in level 2 this time, because I don't want to see that up there again.
That's funny.
Why didn't you come ask them for it? I don't know. It wasn't them who said it, it was somebody in level 4 now who said, I don't know.
Oh, well, they complain about everything though. I have no comment.
Okay, so we want to prevent and manage acute complications. The first way to do that is to recognize that there's a problem. If you don't recognize that there's a problem, the problem can go from your early signs of a mental status change, which are what? What are my early signs that my patient has some problems? They might be confused. They may be sleepy. They might be a little bit confused, restless. Restless is the biggest one. If you have a patient who was perfectly fine a little while ago, and now they're restless, and you just can't put your finger on why, what kind of things might you want to check?
Vital
Might want
signs.
to check their pulse ox, because lack of oxygen, hypoxia, causes restlessness and change in mental status. What else might I want to check? A urinalysis, if this is new, because urine, a UTI causes confusion, especially in elderly patients. What else might you want to check?
Blood sugar.
Okay,
CBG.
electrolytes, which one in particular? Sodium. I'm looking at the BMP and I'm looking at sodium. What other thing might I want to look at on that?
Blood sugar.
Blood sugar, glucose.
Who said glucose? Who said sugar? Blood sugar. What's going to happen if my patient hasn't eaten for 2 days and their blood sugar is 40? Yeah, they're going to be confused. They're going to be restless. They're going to have mood changes. I don't know if I just need to feed them or if I got some kind of neuro problem I need to be calling the doctor about, you know? So checking the blood sugar is a big one. So oxygenation, you can check that just because you're taking care of your patient. Do I have to have an order to check someone's blood sugar?
Nope.
Nope, I don't need an order for that. Do I need an order to send urine to the lab?
Yes.
So do those first ones first and make sure there's not a problem, and then you can investigate further. But if you don't recognize it, it's going to progress into something more. A secondary injury that you need to talk about is a hemorrhage. So my patient got hit on the head with a baseball bat, and they come to the ER. You need need to know the difference between an epidural hematoma and a subdural hematoma. The difference is this: the epidural hematoma is arterial blood. So does this occur quickly or slowly?
Quickly.
Quickly. So I have a patient who got hit on the head, they have an epidural bleed, they have a CAT scan done, and I can see the epidural bleed right there, okay? It's arterial blood. A subdural hematoma is venous blood. Does this happen quickly or slowly? Slowly. It's more of a leaky kind of thing. This is the patient, the little grandma who fell on the sidewalk and hit her head. They took her to the ER. Everything was good. CAT scan looked okay. Grandma seemed okay, so they sent her home. And in 6 or 7 days, the family's back in the emergency room because grandma's not waking up when we're talking to her. She's been sleeping for 48 hours and we can't get her to wake up and respond because this slow, subtle bleed is now causing problems. See the difference between the two? So a lot of times when grandma fell and hit her head, they send her home from the ER with instructions to follow up with her primary care doctor and to have another CT scan in a week to see what the bleed looks like. Then what does intracerebral hemorrhage mean? Yeah, it's actually bleeding in the brain tissue. Because see, this is between the dura and the skull right here, and this is between the dura and the brain tissue, but the intracranial hemorrhage is actually bleeding in the brain tissue itself. Secondary injury can be increased intracranial pressure. So the normal intracranial pressure is 10 to 15. Now can I walk around the room and say, ooh, Chance's pressure is about 12, Lisa's is 15, Dylan's is 17. Can I do that? You have to have a monitor. You actually have to have a monitor in the patient's brain to measure that, but I can detect changes by the changes that my patient has. The most important part here is cerebral perfusion, cerebral pressure perfusion, okay? And that is the amount of blood flow to the actual brain tissue. The way to calculate that is your MAP, which is what? Mean arterial pressure. How do you calculate that? Okay, you don't have to know that in here, you have to know that in level 4. How to calculate. If I give you a question like that in here, I'm going to give you your MAP, I'm going to give you your intracranial pressure, you're going to know what to do with it. The way to calculate your cerebral pressure perfusion is your mean arterial pressure minus your intracranial pressure equals your cerebral pressure perfusion, and we want that to be about 70. 70 is the ideal number. So what are some things that I need to think about to get that perfusion pressure to the brain? If my patient has no blood pressure, are they going to perfuse their brain?
No.
So no, I have to monitor their blood pressure because I have to have some blood pressure. If I have too much cerebral spinal fluid or bleeding in my brain, is my intracranial pressure going to be high or low? High. So those are the things. It's influenced by oxygenation, the blood volume, my blood pressure. I don't want you to get lost about this. I just want you to understand that cerebral pressure perfusion is calculated with your mean arterial pressure and your intracranial pressure. Because we're going to talk all about intracranial pressure monitors and ventriculostomies in level 4. Okay? But you have to understand that if my patient's head is flat, am I perfusing more or less?
Less.
If my patient's head is high Fowler's, more or less?
More or less.
But I want my patient somewhere between 30 and 45 degrees. And I'm going to adjust the head of that bed based on what their blood pressure and what their intracranial pressure is doing.
But if it's higher, then perfuse more or less?
Less.
Less, so-
Less. I don't want it straight up. I don't want it flat. I want it somewhere between 30 and 45 degrees. But what I really want you to understand is if I don't have any perfusion, I'm going to have brain cell death. And so I want to keep that CPP at 70 millimeters of mercury. And And then you have your little formula right there, how to calculate it, but in level 3, I'm gonna give you all the numbers. I'm just gonna tell you in level 4, you're gonna get a set of vital signs, and you're gonna have to calculate it all out, but here, it's kinda simple. Cause on your syllabus, let me see your syllabus real quick. I think it says something about ICP, and, but it's very simple. It doesn't even talk about it, but we're talking about it because we have to talk about mannitol. Mannitol, we love mannitol. Okay, here's our early signs. Change in LOC. What is papal edema? Well, it's actually swelling of the, it's actually swelling around the optic nerve, and you can see it in the patient's eyes. It makes their eyes look like they're, the eye itself is swollen. Impaired eye movement, is that from your cranial nerves?
Yes.
Yeah, that's from cranial nerves. Vomiting with the head injuries. These are your late signs right here. Cushing's triad. I have an increased blood pressure. I have a decreased pulse. And I have a change in respiratory pattern. If I get to this point, did I miss something? Yeah, I missed something along the way. So I'm hoping that over here I can pick up on these things before we get to this. And this, there's a little bit more to this blood pressure. Your blood pressure is going to increase, but the numbers are going to be farther apart. So your systolic blood pressure is going to be getting higher, and your diastolic blood pressure is going to be getting lower. So you're going to see a bigger pulse margin in there. There's more to that. This is very simple. That's the way I want you to keep it, okay? Don't get lost when you're reading. Here's what you need to do. Head to bed, 20 to 30 degrees. What do I say when I say midline head alignment? What's that mean? Yes, I don't want to go in there and have my patient sleeping like this or like this, because what's that doing to drainage? It's impeding drainage on at least one side. So I want to have the drainage open the whole way down so I have good drainage. Why do you think I need to treat pain and fever? Okay, to prevent their heart rate from going up. But if a patient has a fever, it increases their metabolic need, and it also increases the metabolic need of the brain tissue. So if I have a temperature, I want to keep the temperature down. How am I going to do that? My patient's on a ventilator. How am I going to do that?
Cooling blanket.
Cooling blanket. How do I use a cooling blanket? Have you ever seen one? Has anybody seen one at the hospital?
Yes.
So the water circulates through it. Yes, water circulates through it. Now this is what I've seen when I go to the hospital. They take the patient and they put the cooling blanket and they toss it over top of them, and then they toss a blanket over top of them to keep the cooling blanket in place. The right way to use a cooling blanket is the cooling blanket goes on the mattress underneath the patient, because think about that. If this is my patient and I just toss a blanket over top of them, it's touching them in some points on their body, you know what I'm saying? But if I lay the blanket underneath them, their whole body surface is laying on the cold blanket. Is that going to cool them down faster?
Yes.
So I put the cooling blanket on the mattress with the sheet over top the cooling blanket, so they're not laying right on the circulating ice water. And that body surface against that sheet, the cooling blanket, cools them down a lot faster. Monitoring blood pressure is important. Clustering care, what does that mean? Okay, so on this patient, if I'm in there and we gotta give you your bath, and I need you to take these pills, and we're gonna eat your breakfast, and we're gonna clean your bowel movement, and we're gonna do all this stuff, what am I doing to her? I'm stressing her out, and I'm giving her lots of stimulant all at one time. So we can't do that with this patient. We have to avoid clustering care together. We may give you your bath, go away, and come back in a couple hours and do the next thing we need to do. So we're not going to cluster care on a patient who has a head injury and is in the hospital. Noxious stimuli. What does that mean? Okay, smells is one. Smells can be very irritating if you don't feel good, if you have a head injury and you don't, the injury is to your olfactory nerve. noise and light, very irritating. What'd you say?
Like obnoxious things, like.
Obnoxious things like family members. You're in the hospital with a head injury, and your family members are arguing over whether they're gonna get Churches or Popeyes. What do you need to do as the nurse?
Send them to the waiting room.
Remove them. You need to have them step out in the waiting room. You might not need to ask the patient, I'm trying to keep things nice and quiet for you. Is it okay if I put a sign on the door that only 1 or 2 visitors at a time? Or only visiting for 10 minutes at the top of the hour? Because who's the patient advocate? You are. And so if you can see that something's riling that patient up, you need to remove that from the room. Family members are one of the main things that get people all riled up in the hospital. What does that mean, no knee gash in the bed?
I don't even know what that is.
Well, that means, okay, on the bed, how the 2 little buttons, you can put the head of the bed up, and then there's that second button where it puts the little bend in the knee? And you don't want to do that for the same reason you want the circulation, you don't want that little hump there that causes a break in their circulation. Stool softener. Why do we care?
So they don't strain when they poop.
Every time he poops, I have to clean him up. I mean, why do I care? Let it be constipated.
Straining is gonna increase their ICP.
Right, I don't want him to strain. Being constipated is uncomfortable. And if he's uncomfortable, that's gonna raise his intracranial pressure. So a stool softener for these patients is important. Suction him only PRN. Well, my orders say to suction every 4 hours. Do I need to suction him if he doesn't need suction?
No.
Every time I put that suction catheter down to suction him, what's gonna happen to his intracranial
It's
pressure?
gonna go up.
Has anybody ever suctioned a trach for real? Yeah? Yeah. Is it calm like it is in the lab? No. It's very irritating. And as they cough and they gag, the intracranial pressure raises. We're gonna talk about mannitol. What about sedation? What do you think about sedation on my patient who has a head injury?
Be careful.
Be careful with it. Why do you say that?
Because the level of consciousness might go too far.
Okay, it's hard to assess my level of consciousness if I've given my patient a bunch of sedation. Do they give your patient sedation? Yes. They do. Usually they give them something that's reversible, so that if the physician or the neurologist comes in to do an assessment, you can reverse the medication, let them do their assessment, and then give them, they use barbiturates is what they use. So you are gonna sedate them, but you need to do it cautiously, because you can't tell if there's mental status changes if your patient's sedated all the time. So that's used with caution.
I have a question.
Uh-huh.
I had a concussion when I was young, and they said don't let her fall asleep, so what is the reason to?
That is old practice now. They used to not want the kid to fall asleep when they had a concussion like that, but they do let them rest now. I guess the thinking was if you fell asleep, what if they couldn't wake you up? That is old practice though. They used to do that when my kids were little too. Don't let them go to sleep. Yes, fever will increase the ICP because it increases the metabolic need in the brain.
Does that increase their risk for a seizure?
Yes, it does, because if I increase the metabolic needs of the brain and I'm overstimulating it, I can have a seizure also, yes. And we'll talk about seizures, a little bit, but we're gonna talk about it with ICP and level 4, and we're gonna go back to how we're gonna treat those. Mannitol. You gotta talk about mannitol because it's on your syllabus. I still don't know why it's on level 3 syllabus, but it's on there, so we're gonna talk about it. What is mannitol? Oh, you guys know so much. How's it work? Pulls the fluid where? Okay, it pulls fluid from the extracellular space into the intracellular space, increases your volume. So where should I see some results from this? I should see an increase in urinary output, okay? So I'm walking past my patient's room and I don't see any urine in the Foley. Am I gonna freak out?
No, not you.
What am I gonna do first? Yeah, I'm gonna go find my tech and say, you're so good. I know that you emptied that Foley bag and you just haven't had time to write it down. Is that true? And then she's gonna say, no, I haven't been in there. So then what am I gonna do? Freak. I might freak a little bit. I might actually go look at my patient first though, and make sure that somebody didn't put my bag up on the side rail, or,
Make sure it's not a PDA.
right, it's not kinked off somewhere. I might do that before I freak out. That's all good. What am I gonna do now? Okay, I still might not freak out yet. I might do something else first. I might listen to my patient's lung sounds, because before I freak out and call the doctor, first thing he's gonna ask me if there's no urinary output, and you pulled all this fluid in,
Where's it going?
what does she sound like? So I might listen to some lung sounds first. What might I hear? Yeah, I'm gonna hear crackles. If the kidneys aren't working properly and she doesn't have urine output, that fluid has to go somewhere. And it's more than likely gonna be backed up into the lungs, and I'm gonna have my hear crackles when I listen to my patient. And so then that's when I'm gonna call the doctor and maybe freak out for a minute. What else do you think I need to know about this?
Would you need her to know her kidney function, like fun, review it?
Yeah, if my patient doesn't have kidney function, is mannitol gonna work?
Nope.
No, it's not gonna work. I do want you to read the little section in your book about mannitol. There's some safety things. Don't get lost in it. Trust me, you don't need to get lost in it until level 4. But just, it has to go through a filter and just some other little things that are in there. It's like one column of a page. Then nimbutal, this is pentobarbital, and this is the medication that they use to sedate the patient. It's reversible. What is my medication that I use to reverse a barbiturate?
Oh,
Which medication reverses an opioid?
Narcan.
Naloxone, Narcan. Ramazicon is the medication that's used to reverse barbiturates. So I can sedate my patient, especially if my patient's on a ventilator and they're fighting the ventilator. Every time they fight the ventilator, they're increasing their intracranial pressure, so they will keep them sedated, but then they can reverse it so the doctor can do an assessment.
How often would you like to be reversed exactly?
But usually once every 24 hours.
What did you say?
Ramazicon.
You said what, every 24 hours? Or
They usually reverse it when the neurologist comes every 24 hours just to check the patient to see if there's any changes. Here's our surgical options. You don't have to get lost in these. This is a ventriculostomy. It's a tube that goes straight into the ventricular space in the brain and drains off cerebral spinal fluid. Highly scientific. Let me tell you how this works. The doctor says, I want you to drain off 20 cc's an hour, and I raise and lower this chamber to drain off 20 cc's an hour. Do you think you do this on the floor?
No.
No, you do it in the ICU because you really need to be on it, because you don't want to go in there in an hour and have 200 in your bag, especially if you said 20, because you can cause problems draining off too much or too little. Too little, you're not fixing the problem. Too much, it can actually collapse the ventricle and pull the brain tissue away from where it's supposed to be. So, ventriculostomies are not on your syllabus, okay? I'm just letting you know, we're going to do something for this person. They're not on your syllabus. Craniotomies are not on your syllabus either. What is a craniotomy? Right, if I have swelling, they can take a piece of the bone and preserve it, because once that's resolved, they can put that piece of the skull back in place. How do they preserve it? They usually put it in your patient's abdomen. It's just floating around in there. And then once the bleed is resolved, they can go back in and put that piece back in place.
Wait, would in your skull not be generated on?
The bone, once they cut that piece out. They used to keep them in the lab. They used to keep them in the lab, and then they found out that when they would retransplant them in, pieces of the bone tissue was dead. So now they just implant it in the patient's abdomen. What do you think? I'm not concerned about this. What do you think I need to know about this? Right. If my patient is getting better and they're starting to ambulate and stuff, they do have to wear the soft foam football helmet to protect their brain tissue. Because there's really, literally nothing between the brain tissue and the skin to protect them at all. So they do have to wear the little foam helmets. Probably vancomycin and things like that when they're in the hospital.
So they lifelong soft spot, or are they gonna put something back on?
No, they'll take this piece of bone. They'll take that piece of bone right there, once the bleed is resolved, and they'll put it back in.
It's not as strong as
Well, you're still gonna have the suture lines, you know, they're gonna heal, but you're still gonna have them. Craniotomies are in level 4, but the big thing you need to know about them is, if I have this open, I need to protect the brain, and is my patient at risk for infection?
Yes.
Absolutely, because I need to make sure that, there's nothing getting in that space. Seizures we're gonna talk about, with, strokes, pulmonary complications. If my patient's immobile and has increased intracranial pressure, they can develop pneumonia easier. So I need to be aware of that. Can I have some cardiovascular complications if I have a stroke or a head injury?
Yes.
Hypertension, DVTs, I'm in my bed, I can't move. We talked about fevers already. You don't have to pay attention to that. Just understand that if I don't have any blood pressure, I don't have any perfusion. You know what I'm saying? So if I don't have blood pressure, they're gonna give me fluids, vasopressors, and they're gonna search for a cause to bring my blood pressure back up. If my blood pressure is too high, they're gonna give me medications to bring it down. So you don't need to worry about that. You know what hydrocephalus is, we already talked about it. You know what an infection is. What does brain herniation mean? The brain stem, so I have so much swelling in my brain that my brain stem has nowhere to go except to be pushed down into the vertebral space right here. Is that a good thing or a bad thing? Very bad. What happens in your brain stem? What's it control? Breathing, heart rate, all those things. And so if it's herniated into the brain stem, it's not working anymore, and your patient's probably not going to make it. You know? So we're going to all make it in level 3, though. Level 4, we might die. We talked about the dimension there. We'll talk about the diets when we come back, and the speech and language things, and then we'll focus on strokes, multiple sclerosis, and spinal